All right, I think I just started the recording. All right, so Bio 139, what is this, January 28th, Lab 2, Thursday lab, got the EKG. I suspect this will probably be a shortened lab. And then we will break and hopefully get home safely for some of us who came to lab tonight. All right, so EKG. Let's talk about, first, let's go through page 17. The problem, it's going to be kind of like last week. A lot of the first part of the lab is memorization, okay, which is the pictures I sent out to you guys last week also covers lab 2. All right, I know there were some complaints about the quality of picture. Well, it's just they're old pictures, and that's the best that we can do. For you guys that are in person tonight, the pictures are in the back. If you want the answers to the lab, it's in the back. So you may want to either jot them down or take a picture of them for your study purposes. I won't cover too much of the heart, and we can if you want, but a lot of it's just memorization, flashcards. I will probably talk about different parts of the heart that that are involved in EKG and what it is, but in regards to pointing things out, there's really nothing to add. It's just really going over memorization and flashcards. So that's going to be a large part of this lab. And the pictures are in the back. And you guys, if you dig into your emails, I think from last week or the week before, when I sent you all those pictures, I think that was for both lab 1 and lab 2. I did not know that at the time, but it's still back there. Okay, so I'm scrolling through page 17 through 21 through 22. Make sure you try to identify all those on the pig heart. We have pictures of that page on page 22, I think. And then now we start EKG. So let's talk about EKG.
Where's the pig part?
Page 20. Do we have anything on page 22? We don't have pictures, I believe. I think it's just the identification of. Do you all not have a page 22? With the yes. So that's where we need to identify on the pig, each ones. Now we could probably pull the pig out tonight and try to look at it. We'll see how detailed we can be. There may be pictures in the back of what the pig looks like, with these answers pointing to the pig. During the quiz, you know, obviously with this being everything going to be online, is that we're going to have to identify pictures, right? We're not doing it in person. So a little bit easier, I think, because you got to, you know, it's easier. Okay. Let's talk about EKG. I may shut this door too. EKG. All right. So what's the heart do? What's the heart do?
Pumps the blood.
Pumps the blood. Pretty simple answer, right? For us to pump the blood, what has to happen?
The heart has to contract and relax.
Yeah, heart has to contract and relax. All right, we're getting good, getting warmed up here. So I may just answer this one myself because I probably can't pose it as a question. When the heart has to pump blood and contract, there is something that happens that causes the heart to contract, and that is electrical conduction, otherwise known as action potential, otherwise known as depolarization, repolarization. I'll use all these words tonight. And what is, when we go to the hospital or we get picked up in the ambulance, does anybody know, like, the first, or going anywhere really, what the first few things, I guess I want to call it, what a nurse or a doctor would do to you? Take your blood pressure. That's right. That's like number one. And then, so if you think that you have a heart condition, or you come in with shortness of breath, or you come in with left arm pain, or indigestion. All these are indicative of what's called an MI or myocardial infarction. They'll hook you up to a EKG. Okay. EKG is like the second thing they do. And an EKG is basically what is demonstrated on page 23. Okay. That is what a normal EKG looks like. And what this is measuring is basically it's measuring the electrical conduction of the heart and the contraction that happens subsequently of that electrical conduction. So when I ask you all these questions about what the heart does and what makes it go, what really makes it go is the electrical conduction that causes the muscles to contract. Okay? So when in the movies, we've all seen this where, somebody goes what we call asystole, which is their heart stops or their heart is out of rhythm. That's a big deal too. We kind of talked about that last week, arrhythmias. And what happens is that they will get what? Get the paddles out, right? And have some dramatic scene of shocking somebody. And it is kind of dramatic. It's dramatic for sure. So what that does is that it administers a shock to try to get the rhythm, the electrical conduction rhythm back in sync, okay? So you can get somebody out of fibrillation or get their heart started again. Does anybody know in the heart where this occurs? You probably don't. It's called the SA node. You might have heard it before. It's called the sinoatrial nerve. Excuse me, node. It's not nerve, it's a node. And what I mean by node, it's really just like a pocket of cells that are a lot different than other cells around it. And they help through physiology, will help fire and action potential together. And does anybody remember what an action potential is for Bio 137? That's pretty much a bunch of flows of electrolytes, sodium and potassium mainly. So you get this influx of sodium, which causes the electrical conduction to spike, and then it'll go down when potassium comes in. And they do this all together. So all of a sudden, they send this electrical conduction through the SA, out of the SA node, which is located in your upper right atria. I said left atria on Tuesday. I screwed up. I had to correct myself on YouTube. It's upper right atrium, and it'll travel from the atrium into the ventricles. And what this does is that it will cause these cardiomyocytes, these cardiac muscle cells, to contract in what we call syncytium, which is together. The fancy word is syncytium. And then what's it do? Pumps the blood. That's the purpose of it. So to move oxygen and to get rid of our CO2 and when it comes back to the lungs. Okay. So this is an example on page 23 of a regular EKG. All right. Let's see. I think I want to add anything there. Okay. Now, I think on Tuesday's lab, I had a EKG tech in my class, and I told her, I said, if I misspeak or if you know something a little bit more interesting than what I'm saying, speak up. I mean, I guess she said she was pleased with it. I'm not trying to boast, but I was waiting for her to chime in and correct me on something on like EKG. If she does this every day, surely she knows a little bit more in depth than I do. Probably beyond the scope of the class, but that's okay. So does anybody know what these things are they put on their chest?
Ooh,
Leads. Yeah, they're leads. And what these are, they're like electrodes, okay? And what's an electrode, right? What an electrode is a sensor that is very sensitive and will pick up on electrical conduction. It's the flow of electrons, okay? We can kind of get into physics if we want. And or anything, electrons or anything. Chemistry, really. Takes you back to Gen Chem. But each of these leads have these different planes, okay? It looks at different planes of the heart. You'll have an X plane, a Y plane, and then you'll have a Z plane, which is going in and out, okay? It's hard to imagine the Z plane because that's more like the 3D plane. So then the doctor will get, he or she will probably prefer a a specific, you know, plane, probably an X plane, and they will read it. And depending on what they see on this graph will dictate whether this person has had a heart attack or not. I think there's two versions of a heart attack. There is a STEMI, which I wish I knew the definition of that. I used to, but I'm not confident enough to talk to you guys about it. A STEMI is more, a STEMI, STMI, STEMI heart attack goes to, that is the more serious one that will go to the cath lab. If you have one of these out in the county, they'll call a helicopter in and fly you in because you need a cath lab, you need it quick. And what a catheterization, cardiac catheterization lab does is that it will insert a stent. They'll go into your femoral artery and they will travel up to the heart using a, I guess I'm going to call it a stent. And basically what they do is they kind of blow up your arteries and veins to remove the clog. Okay. Sometimes when I'm at work, sometimes these procedures go bad and some people survive it, some people don't, because you're basically busting up a clot somewhere in the carotid arteries where they've had the, does anybody know what the carotid arteries do and why they're such a problem? Carotid arteries are right off of the heart, and those are the arteries that perfuse the heart itself. We have blood that runs through the muscles and all that, different arteries and veins, but the ones that always cause the heart attack are the arteries that actually are responsible for the metabolism of the heart. Okay, because if you think about it, the heart's an organ too. It's going to need nutrients and oxygen and everything else. And there's 5 of them, and they're right off the heart. And sometimes they can get really small. And when we have poor diets or sometimes genetics or stress, they can get clogged up easily. And that's how we have to get open heart surgery, as they call it. But to get back on track, let's talk about the electrical conductions. So they can read these EKGs to determine if you've had a heart attack and what kind of heart attack. They can also order a lab called a troponin value that will determine if you've had a heart attack or not also. So they can read an EKG, which is fairly quick. A troponin may take 30 minutes, 20 minutes to run. An EKG, you know, I think you probably have something done ready out to you in 5-6 minutes. So they already have some kind of differential diagnosis of what you know, kind of heart attack you do have. So it's a quick tool. It's a quick tool. It's been around for a long time, and you can get a lot of information from it. All right, so let's talk about page 24. Let's talk about page 24, and let's everybody take a look at this. And I may mirror my image for you guys. Oh, Andrea, I just saw your chat. Hold on here. Leads. Yeah, okay, yeah, there are leads. All right. Now, let me share screen. Let's do that. Okay. All right. So, page 24 we have on here. We have all these different what would look like one cycle of a heartbeat, okay? Of an EKG. This is what a normal EKG looks like. Okay, so I said in the beginning that it originates in the right upper atrium of the heart. That's called the sinoatrial node. When this, and you have to think about this, we're not talking about contraction. This is what happens before contraction. When I mean contraction, I'm talking about the heart beating, right? Lub dub, lub dub, lub dub. This is what causes lub dub, lub dub. This is like the preeminent phase of the lub dub, because for me to move my arms, they have to have a signal from my brain, a conduction signal to move my arms. I just don't just do this randomly. And this is kind of what the heart's function is. This is called the autonomic nervous system. We have no control over it, whether if you get like, if you have like a panic attack or something like that, or stressed out, you can, or you're nervous, you can kind of pick up on the autonomic nervous system causing, an increased heart rate. So P, the P wave. All right. The P wave is what's responsible for the atrium to contract. Okay. Now, does everybody know the flow of blood? Like where we start? We'll go over this. Let's go over this real quick. So let's start at the left. Let's start at the left atrium, which is the upper right. Let's see if I can get up. I'm going to draw my makeshift heart. Yeah, that's like Valentine's Day right there. Okay. So this right here will probably be, this is the right atrium. This is going to be your SA node. Okay, this is where it'll, yeah, this is where it'll start. It travels down into something else called the AV node, which is the backup for the SA node. So if the SA node, where like people have pacemakers, you ever heard of the pacemaker? This is when these don't work. When these don't work, you have to go in, you have to insert a pacemaker, and that's pretty much a new SA node. These cells are designed to be anywhere from 50 action potentials to 130, 140 action potentials per minute. And if you think about that, that's about the same thing of a heart rate. Okay, that's your heart rate. They're designed to do that. If for some reason they fail, the AV node can back up, but it has a much lower firing rate. So if you think about it, a much lower heart rate. You're still surviving, but you're like barely surviving. You know, it's like barely just getting blood out to the oxygen. And if you think about it, if you pass out and you hit your head, you're pretty much done. So this is kind of, sometimes this is how the heart can affect the brain. If the brain's not getting enough oxygen or blood to it because the AV node's in control and the SA node took the day off, then you could have potential problems. Because if you pass out and you faint, then you could hurt yourself that way. So now let's talk about, let me just get this septum in here. This is a septum. This is what splits the ventricles, all right? So over here, we're gonna have the right ventricle. We're gonna have the left ventricle. And then we're gonna have the left atrium. Okay, I'm drawing this from the patient's point of view. So be like this. It will, after the electrical conduction fires, it'll come down to the ventricles. And what happens is that this electrical potential will go through what's called the Purkinje fibers. And the Purkinje fibers will, it's a highway for electrical conduction. And what it does is it'll bring the electrical conduction down and then towards the end, and it'll contract the heart from the bottom up. Because if you think about it, all the valves, all the release valves, aorta, pulmonary vein, et cetera, they're all at the top of the heart. So when we contract from the bottom up. And I think so. Let's talk about the flow of blood. So when we have the right atria, blood will flow into the right ventricle. From the right ventricle, they go to the lung to get oxygenated. That's deoxygenated blood in the right atria and right ventricle. They go to the lung to get oxygenated. Therefore, when it becomes oxygenated, it will return to the left atrium, flow down into the left ventricle, and the left ventricle is the one that has all the has the high pressure, right? Because it has to pump against the systemic body. So that's, you know, when we talk about blood pressure of 120 or 120 milligrams per mercury, mmHg, that is the blood pressure against the heart to go into the body. Does that make sense? Because you're pushing all this blood and it has to fill up everywhere else in your body to perfuse it. So that's the flow of blood. I think we probably need to go over that because it makes more sense. Okay. Now back to the electrical conduction. Let me see. Okay. P wave. The P wave is the part of the EKG that is responsible for the atrial contraction, otherwise known as atrial depolarization if you remember your action potential, you have a depolarization and you have a repolarization. The depolarization goes up, that's the influx of sodium, and then the repolarization is the influx of potassium. All right, so now that we've initiated atrial depolarization or atrial contraction, that will kind of push the blood out of the heart. Now, it does this, it probably pushes about 80% of the blood out into the ventricle. The other 20% is from gravity. And you have to think about it. Since we're moving blood, it takes time to do this. This is what the PR segment is for. The PR segment is pretty much the millimeters per seconds. Like we're talking about millimeters per seconds. Small, like individual, less than seconds. Because if you think about a heart cycle, lub-dub, it's milliseconds. So the PR segment is milliseconds. That's the time it takes for the blood to move from the atrium to the ventricle. All right. Okay. Let's talk about the QRS complex. This is the big one. This is the big one. And if you think about it, this is what happens when we are contracting the ventricle. The ventricle is big, right? It's this whole thing down here. It's got a lot of cardiac muscle, particularly on the left-hand side, because it has to force blood against that resistance in the against the body. So we have this huge depolarization of the QRS complex, and what this is that this is the electrical conduction that is pretty much wrapping its way around these ventricles because it's going to cause it to contract, and that's called ventricular depolarization. We have atrial depolarization, which is the P wave, and then we have the QRS complex, which is ventricle depolarization. Now, from probably the R to S, that's when we kind of get more repolarization. So at this point, the muscles are contracting. Blood is starting to become ejected from the heart. And the ST segment, that is the time it takes for the blood to leave the ventricle. If you think about it, it's a tad longer than the PR segment. And that's just because we have a lot more surface area to eject, a lot more blood to eject. This is what we're going to talk about next week in stroke volume. So the ST segment is the time it takes to eject the blood out of the heart. And then the ST wave is that is pretty much ventricular relaxation. Okay, so once if you contract a muscle, you cannot sit there and keep it contract. It has to relax at some point. The T wave is what we call ventricular relaxation or repolarization. It's just relaxing for the next. It's getting ready for the next fill. So there's two other vocabulary words I need to introduce, and they're systole and diastole. Does anybody know what systole is and diastole are? I guess is and are.
Diastole for relaxation.
Blood filling, yeah. So diastole is relaxation. This is the moment of the heartbeat cycle that will relax and allow blood to fill the ventricles or the atrium. Systole is just opposite. It's the contraction. It's the contraction of the heart, and it causes the blood to eject out. So just two vocabulary terms we probably need to talk about. Okay, so now those are the high points, I think. Intervals, yeah. Now, I'll be honest with you. The PR interval and the QT interval, I never learned what those are. I'm not sure what they may be a breakdown of some pathological states. If you have like AFib, atrial fibrillation, or some kind of MI. I'll have to look up in what PR interval and QT interval are. The PR segments and the ST segments, I want everybody to understand that's just the time it takes to move the blood and to get the muscles somewhat reset. TP segment. Now, one thing we didn't talk about, you probably heard me talk about ventricular contraction and ventricular relaxation. You know, that's the big ventricle. In the P wave, I told you that that is the atrial contraction or atrial repolarization. But I did not mention anything about atrial repolarization or atrial relaxation, because we've already contracted the atria, right? Now it has to relax. So we should see that in the EKG of it relaxing. However, you don't. And there's been questions on this in the past, like which one is atrial repolarization? And the answer is that you don't see it because it's overshadowed by the QRS complex. The QRS complex overtakes the atrial repolarization phase. We see it in the T wave. That is the repolarization of the ventricle, but we do not see the repolarization of the atrium. So don't be fooled on that. It's non-existent. It's there. It's just hidden behind the QRS complex, and we can't see it. It's too small. Atria are small. Ventricles are huge. Okay. Let's talk about number 6 here. Control of. So I kind of mentioned earlier. You might have picked up that the SA node pretty much controls your beats per minute, right? This is depending on how many action potentials they fire will dictate your heart rate. Now, if you're in really good shape, like let's say you like these swimmers, man. I used to swim in college, and I thought I was in the best shape ever. That's how I got my stress out. And I wish I still did it. It's just too much trouble. I need my own pool. If you were in awesome shape, let's say if you're like an Olympian, or even you don't even have to be an Olympian, what do you think your resting heart rate would be? So you might have an idea. 90 is about average. 80 to 90 is about average. So these people can probably get a resting heart rate down to their 60s. Some crazy like mid 50s, mid to high 50s, but maybe between 60, 65, 70. So what that means is that the heart does not have to work as hard. It's the muscles so much better developed that it can pump enough blood to satisfy the requirements of the body, even under exercise. Now, somebody has a failing heart, or somebody's, let's say, out of shape, then their heart rate can be anywhere from 110 to probably not 110, 120 if you're on drugs, 130, 140. Got some cocaine in you or something like that, some stimulant, meth. When you are in AFib, atrial fibrillation. So what this means, when I say fibrillation, we talked about atrial contraction. Normally, we'd have atrial contraction. When somebody's in atrial fibrillation, when I don't think about it, I can say the word fibrillation. It's a flutter, okay? It's not a full contraction. It's a flutter. And what happens is that there's not a lot of blood. The gravity part's happening, so we're still getting 20% falling, but we are not getting the full ejection into the ventricle. Therefore, we're not pushing a lot of blood out to the body. Therefore, the heart has to work harder to compensate that fibrillation so we can stay alive. A lot of old people have this. Elderly people have AFib, and a lot of them are on anticoagulants. I'll talk about that next. So what was it? Mom called me last fall, and she says, your grandmother's down in the hospital. She's got white fingertips, and her gums are white. She's 86, and she went off of her AFib medicine. She just decided she wasn't going to take it anymore. And what happened is that when you have your white fingers or your gums are white, that is what happens when you're not getting blood perfused, right? Like blood's not reaching the tips of your fingers, you're getting poor circulation. Eventually you could probably succumb to this because you're having lactic acid build up in your body and your pH gets all thrown off and you can probably pass out or fall. So she was in what they call an arrhythmia. And what they had to do is that they had to get the paddles out and they had to give her a mild shock to get her heart back in rhythm. They tried to do it with drugs and it didn't work. So this was the next step. And basically, essentially, it goes right back into, it's called a cardioversion. And it's a low shock, a low voltage shock, and they just zap her real quick. And I think she was fine, and she's always, she felt fine at 87, 88 years of age. So that's what they have to do. Now, why do these people take anticoagulants? All right, well, think about it. Anticoagulants help the blood not to clot. If there are two types of flows, there is this called laminar flow of blood, and there's this turbulent flow of blood. So if you have this flutter, right, you're really not moving much blood at all. Laminar flow is normal flow. Turbulent flow just kicks blood around a lot. Like atherosclerosis happens when your arteries harden. You get this turbulent flow, and it's not good. This will create clots in the atria, small clots in the atria, and then they get big enough that they start to pick up weight, and then they'll drop into the ventricle, and as soon as they drop into the ventricle, they're out in the body. So you got this big ass clot rolling around your body, which you not should. What happens to clots? What do clots do? They block up stuff, right? If they block your head, there's your stroke. If it's too bad, it blows a hole in your artery or your vein, and you have what's called a hemorrhagic stroke, and you're going to check out in the next 10 minutes. That's about 20 to 30% is what happens when you have a hemorrhagic stroke. Chances are you're not going to survive that. They'll rush you into emergency surgery, and you'll take a lot of blood products because you'll have a brain bleed, but a lot of times it has a poor outcome. If the clot goes into your lower regions, that's called a DVT, a deep vein thrombosis. You've heard of that too. COVID is causing deep vein thrombi. They're not sure why, but they're ordering a lot of coagulation assays or tests because it just so happens that this COVID virus in some people are hyperactivating their coagulation systems. And it's kind of interesting. They're trying to figure out how and why. So to go back to what we were talking about on page 6, when you have the control beats per minute is normally around 60 beats per minute. If you were to exercise, you can go anywhere from 100 beats, 120 beats, even higher, maybe 150 beats.
I'm sorry.
Yeah, what's up?
Page 6.
Huh?
Where's page
Oh, I think we're on page 25.
25?
Okay. Did I say 6? I'm sorry if I did. Now, maybe I meant to say 26. That's what we're going to do next. This is a case study. I'm going to read it off to you, and we're going to work through it. So after a fairly, and I'm going to get back to stop sharing my screen in case you all chat me something because I can't see it where I'm at. Okay, we're going on the chat. So after a fairly severe heart attack, the EKG reveals normal sinus rhythm, but only for the P wave. The QRS and T waves are no longer in synchrony with the P wave. So what does this tell us? Well, we said that the P wave does what? The P wave controls the atria. Yeah, that's the first one. That's the atria up there at the top. So we have normal blood coming through here. Then when we have the QRS-T waves, those are no longer in synchrony. So something's going on with the ventricular contraction, which is a serious deal. When you have ventricle problems, then you're likely not getting enough blood out to the body. So that's the problem. The problem lies somewhere in the ventricle because we're not having the QRS and T waves are off. I think we already answered part B. So what's the heart damaged? The ventricle. Okay. And I did not understand this question on Tuesday, but I think it just dawned on me. What is pacing the ventricles? I think what we're trying to ask is what is the pacemaker of the ventricle, right? What's causing the ventricle to go through its rhythm? And I think the answer here is AV node. Because if we have normal SA node, it travels to the AV node before it comes over into the right ventricle. So I think the question that we're trying to get here is it's going to be the AV node. There's only two pacemakers, right? SA node, which is the one that normal people have, and then the AV node would be the backup. Okay. So we have normal and abnormal EKGs. I think that last one is an abnormal EKG. That is on page 26. The normal ones are there. Excuse me. I think it's the last two that are probably abnormal. So the first two are no, excuse me. The top one is normal. The bottom three are abnormal. And does anybody have it in front of them? Page 20. Okay. So if you look at 26, and for you guys online, the top EKG, or excuse me, ECGs, ECG and EKG, I believe, are the same. The top one is the normal one. The last three are abnormal. The second one doesn't have a P wave. It only has a QRS and a T wave. It doesn't have the first part. The second one has intermittent lack of QRS complex, the yellow one. See, like it has a P wave and all of a sudden nothing happens with the ventricle after like 3 or 4 heartbeats and it comes back. I don't see how that's not lethal. And then I think the last one, don't quote me on this, but I'm almost positive that is something like of a fibrillation deal where you just had this flutter. There's no like boom, boom, boom. All it is just like this. It's just not doing anything. Okay. That takes us through lab 2. It's quick. Next week we're doing heart, and we're gonna talk more about this. And I'm gonna end this here. I'm gonna talk to a few guys in person, but that's all we're doing today online. Is there any questions right now? If you've emailed me, I haven't had a chance to check my email. Okay. All right. Reach out to me. Make sure you do the quizzing. It's due tonight by midnight. There is a boo-boo on question 10. It's worth 10 points. It should be worth 1 point. If anybody got my email, don't sweat it. I'll have to fix it. I have to manually grade everybody's quiz, so your grade will likely change. If you misspelled something, you got it wrong, you'll probably get it right if you're close to the correct spelling. Okay. I'm gonna turn you guys loose here and talk some class. All right. See you later.